Well, ladies and gentlemen, this is it. Here we are. Chapter number 13, our final topic for this month and this course. I hope that the lectures that I've provided to you have been informative. I know it is not the most riveting information. It's not the most exciting stuff. And some of it's really not even all that new. But as part of this course, we wanted to focus in on some of the details when it comes to all these different conditions and disorders, and we have done that through this. I hope that you have enjoyed the opportunities to go on field trips and actually see real people that suffer from some of these conditions and meet real professionals that work with people with these conditions, because that, to me, and that's something that we agree on here at Kaiser, particularly in Jacksonville, being able to see and hear these things is really where the primary learning takes place. You just listening to this, while there is some benefit to you, and you will want to listen to this because there's a bonus question for this quiz, and I will include some additional information when I get to that spot, so stay tuned. Just listening to this is not going to help you learn that much about it, not as much as actually hearing from people of how they work with it. This class is really designed to tell you a little bit more about these special populations and these conditions and disorders, and in the hopes that you remember some of it, but you always know where to go back to in order to find this information, because you're not going to be an encyclopedia for all of this. You're not going to be a textbook for all of these special populations. But as a professional, you do have a responsibility to provide safe and effective workouts for these folks. And what you need to know in order to do that is where to go to find out the information that's going to be the most helpful. So without any further ado, let's finish this out strong. We are talking today about the ladies. We are talking female-specific conditions. So here we go. We open with the female athlete triad. It is an interrelationship between energy availability, menstrual function, and bone function. So that's 1, 2, 3, a triad. So energy availability, menstrual function, and bone function. And clinically, we see this manifest itself in the form of eating disorders, amenorrhea, or the cessation of someone's menstrual period, and osteoporosis, which we know is clinically low bone mineral density. So how does it happen? What are the risk factors? Typically, this happens for females that play in sports that specifically require body weights to be monitored, social isolation, exercising more than necessary for a sport, pressure to win, punitive consequences for body weight gain, so that being frowned upon, and having parents or coaches that are controlling or overbearing. These are things that are likely to contribute to someone actually having or coming down with the female athlete triad. So there you see it. Disordered eating, loss of bone mass, menstrual dysfunction altogether is what we're talking here. And there are some signs and symptoms. We're not going to be in the business of diagnosing them, but you see them here. So people kind of watching. The disordered eating patterns are something that usually get more noticed by others. The others not quite so much because they need to be clinically diagnosed. Other early detection signs, overtraining, recurrent non-healing injuries, being in a sport where you have to keep your weight very low. All these are pretty, they're a lot like the risk factors we mentioned. For the athlete themselves, common signs and symptoms: irregular or absent menstrual cycles, constant feelings of tiredness and fatigue, sleeping disorders, and things like stress fractures and recurrent injuries. That's not normal in a healthy young individual, and it tells you that something is wrong, and it could very well be this, the female athlete triad. Other things, and someone might not realize they're doing it, but this begins to show something that we'll get to when we start talking about a couple of different eating disorders. There are a lot more that are actually even in the book, but we're going to keep it focused on the most common ones, just so you're aware of them. But if someone is looking to always be thinner and really restricting their food consumption, their feet and hands are cold, eating less food than what's needed in an effort to perform or an improved performance or physical appearance, these are bad things, and they are on the path to something being seriously wrong. So after the age of 11 or 12, low energy availability or energy deficiency can disrupt the proper functioning of the reproductive system in girls, so resulting in irregular or less frequent menstrual cycles. So this is oligomenorrhea. This is irregular menstrual cycles. If they miss 3 or more, so if there's a few consecutive misses here, that is considered amenorrhea. Okay, that is a stopping of the menstrual cycle. If the menstrual cycle stops, then there is less estrogen being produced. And table that for later, because that estrogen is going to be a big topic here when it comes to bone health, which is where we find ourselves now. Osteoporosis is that progressive bone disease that's characterized by a decrease in bone mass or bone mineral density. Now, when there's less estrogen available, so when the menstrual cycle gets disrupted. And keep in mind, it gets disrupted because they're not eating enough food to keep enough body weight to maintain their menstrual cycle. But that estrogen goes down, and that loss triggers bone loss as well. So that's osteopenia, when you start to lose normal bone mineral density. And if it becomes more long-term or it gets worse and worse, then it can lead to full-blown osteoporosis, which is traditionally reserved for older women and older adults. But it can happen in athletes as part of the female athlete triad. As a result, there's an imbalance in the bone remodeling process. This is secondary to the decreased energy availability, so it's not even just that anymore. Loss of estrogen eventually leads to brittle bones, and those are more likely to be damaged both during activity and later in life as bone loss progresses. So even if you're able to fix this issue and get back to normal, you are now more at risk for bone issues later in life as well. Loss of bone mass is also related to deficiencies in consumption of calcium and vitamin D. So when we talk about exercise and how to intervene and maintain body weight properly and keep people from getting this, we're going to talk about incorporating calcium and vitamin D into someone's diet. So then we get back to that energy availability or eating disorders here. Now this gets into the DSM-5 by the American Psychological Association, the APA. Yes, the same APA that is responsible for the formatting of your papers and such. The DSM-5 defines feeding and eating disorders. These are, again, in no particular order here, but anorexia nervosa, which we sometimes know as just anorexia, bulimia nervosa, Pica, rumination disorders, avoidant restrictive food intake disorder, and OSFED, or other specified feeding or eating disorders. We will mostly spend time talking about the first two, since they are the most common, and they're the ones that we'd be most likely to encounter at some point. So what actually causes someone to have an eating disorder? It's thought that it's both biological and environmental in nature. Variables from both seem to play a role in causing these disorders, but medical treatments are effective, and they can include changes in diet, psychological treatment, and even prescription meds. After about 5 years of treatment, about 70% of those with anorexia and 50% of those with bulimia recover. So that is an encouraging statistic. Being treated consistently for several years, they can recover. Binge eating disorder recovery occurs in 20 to 60% of those affected, so that one varies more considerably. We're not going to talk a whole lot about binge eating disorder. We're going to stick mostly to those other two. So here it is, anorexia nervosa. Now, keep in mind that this is in the female-specific conditions. It can occur in men, although it is very, very uncommon. It's like 2% of all those affected, maybe 1%. In fact, this is the source of your bonus question in the quiz for this last chapter. In 1999, the lead singer of a band in the 90s known as Silverchair, he came out as someone who actually suffered from anorexia nervosa. In fact, they had a hit song at the time called Anna's Song that was a reference to his fight and his battle with anorexia nervosa. So there is at least one famous example of males coming down with this disorder, but it is primarily female, which is why we find it here. So for that bonus question, the band is Silverchair. The color silver, a chair like you sit in, but it's all one word, Silverchair. It's characterized by low body weight, obsessing about body shape and size, including the desire to look thin. In that person's eyes and their mind, they never look thin enough, no matter how thin they are. Fear of irrational fear of gaining any body weight, and then restrictive eating behaviors to keep in line with those desires. Behaviors include weighing oneself very frequently. They might use laxatives or force themselves to vomit. These are symptoms that sound a lot like bulimia, but this obsession with body shape and size and looking incredibly thin are really what makes this its own disorder. Anorexia nervosa arises from a complex interaction of psychological, behavioral, biological, and social variables. Someone that has this will look like they have this. Brittle hair, nails, dry yellowish skin, constipation, muscle wasting and weakness, low blood pressure, sluggishness, reduced body temperature. You can usually look at someone and wonder, and this is something critical. Now that doesn't mean you could just diagnose by visual, but it's one that is not easily hidden. Greater risk of heart damage, too, for those with anorexia, which increases the risk of a heart attack, heart-related problems, and even death. Medical treatment includes helping to restore them to a healthy body weight, and this usually requires intensive psychological therapy and helping to reduce or eliminate behaviors and thoughts that contribute to these issues. Now we switch to bulimia nervosa. So we went from anorexia now to bulimia. That's a repeating pattern characterized by binge eating, so they overeat, followed by a compensatory behavior to purge and get rid of all those calories that they just had. So it's binge and purge. Those behaviors include forced vomiting, so that's the most common one most people think about with bulimia, is that someone might put their fingers down the back of their throat and vomit. But that is not the only method of purging. It could also be the excessive use of laxatives or diuretics to just flush everything out of the body as fast as possible. Could be excessive fasting afterwards. Excessive exercise, and I mean excessive exercise, to just burn all those calories that they took in, or some combination of all of them. But it's binge, like eating way too much, binge, 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 and then purge, purge, purge. Get rid of it all. Now, before we do OSFED here, I will say that bulimia, unlike anorexia, does not present itself the same way in terms of, like, you can't really look at someone with bulimia and figure out that they have bulimia. Okay, they look like a normal weight because they just take in a lot of food and then they get rid of it all, and it leaves them back wherever they started. Typically, you will see someone get diagnosed with bulimia nervosa. It gets caught oftentimes by their dentist because the acid content of their vomit might actually wear away the enamel on their teeth and can lead to some issues from a dental standpoint, so they can pick out if someone is vomiting excessively. You'll also see burn marks on their second knuckle or on their first knuckle of their hand just from shoving their fingers down their throat. Again, that acid burning the skin. So those are some ways to identify bulimia. OSFED is the last disorder in the list. It's non-specified. It can include atypical anorexia nervosa, atypical bulimia, and binge eating disorder, purging disorder, and night eating syndrome. So this one, not quite as common. We'll kind of go quickly by it because it's not something you're likely to hear much about, but it's in here. Pica, however, I will say something about. It's something that actually sometimes happens in pregnancy. Women will get these cravings that are not for food. And so this is having an appetite for non-nutritive substances, like someone wants to eat paper or chalk or sand or dirt. Complications are associated with the consumption of these substances because they can't be digested, and they will lead to blockages and other gastrointestinal problems. So there's pica for you, and that's something that can actually happen both during pregnancy and independent of it. It's an interesting one. Rumination effortless regurgitation following most meals induced by involuntary contraction of the abdominal muscles, where there's no retching, nausea, heartburn, odor, or abdominal pain associated with the regurgitation. So there's another one. Again, not super common, but Pica, keep that one filed away for later. All right, so exercise. Listen, here's the thing. They don't have as much energy to begin with, so caloric expenditure from exercise is bad. We don't want to have any more caloric expenditure because that could really affect them. It could be exacerbated, these effects, by more caloric expenditure. However, as treatment progresses, as they get to a healthier state in life, you can start to reintegrate exercise because it does have benefits. Energy availability can improve, that bone mineral density that is lost, and normal estrogen levels that are depleted, that were depleted before, those can come back. It takes several years, but strength training and exercise can help with that once they begin to get back in some of those other areas that other doctors and psychologists can help with. Returning to the last body weight where normal menstrual cycle or menses were last observed should be a benchmark for their normal energy status. That's going to be something that tells us that it is safe to begin work again. And keep in mind, a doctor's clearance is going to be there for all of this. Now, if you're working with someone that has this or has had it, keep in mind you want to shift attention away from training and competition instead to treatment. Again, this depends on their medical status, but make modifications to exercise prescription to decrease overall energy expenditure. Don't put them on the scale. Don't make that a benchmark that you want to look at as a measurement, because that obsession with the scale and that body image can be a real problem. You're going to have to kind of think a little more critically here. However, this one here, this is a little note, a little message for you. It's recommended that the calculated body mass index, BMI, be increased to greater than or equal to 18.5. Remember, when we talk BMI, we know 25 marks the spot at which someone is classified as overweight. That normal weight ranges from all the way up to 24.9, but starts at that 18.5 kilograms per meter squared. So that is going to be considered normal, 18.5 BMI. I mentioned it earlier. Recommend that they take more vitamin D and calcium. Resistance training can help with the bone mass and muscle strength, but again, because of the bone density issues, high impact activities, those should be avoided. Now we move to something more positive, and that's pregnancy and postpartum. And there are a lot of benefits for being active during pregnancy, and there is little risk to mother if there are no already pregnancy-related complications. So if it is a healthy, normal pregnancy, then exercise is something that should absolutely be a part of it. It can help to maintain health and fitness levels. It can assist with weight management, reduce the incidence of gestational diabetes. We'll table that for later because research does not necessarily 100% agree on that, but if it's even a possibility, why not? And then improve psychological health too, because there's a lot of stuff that's going on during pregnancy. Being physically active during the postpartum period can also assist in weight loss and improve fitness levels and psychological well-being. And guess what? This is a great benefit too. It does not affect breastfeeding, which is great because that's what the postpartum woman is going to be concerned with, if that is their choice in terms of how they're feeding their child. We're going to spend a little time on some hormones here because these are some of the questions from the quiz. So we'll look at these hormones listed here, and we'll start with estrogen. Estrogen has an anabolic effect on the body. And remember, we talked about estrogen. It comes up as a female-specific hormone. Anabolic effect on the body. It helps promote breast tissue development and blood vessel enlargement. It also helps to regulate levels of progesterone. These hormones increase 100 times and 10 to 15 times during pregnancy, respectively. So humongous increases in these hormones. Human placental lactogen. This can function like growth hormone to alter metabolic properties in order to deliver more energy to the growing baby. So that's the purpose of human placental lactogen. It's to get more energy to a growing baby. Fat breakdowns also increase and delivers more free fatty acids to the growing baby, which they need for that normal development. And that's why having the right kind of caloric intake from the right sources is important, because without it, hypoglycemia, so low blood sugar, can occur, and that can affect the woman by causing nausea, dizziness, fatigue. So maintaining proper glycemic index levels, not index levels, just having the normal amount of blood sugar. Your blood sugar level should be normal. It is a known fact that women will gain weight during pregnancy. However, there is such a thing as too much. That whole, oh, I'm eating for two? No, that is not a solid recipe for success for helping your baby be healthy. There are some more recommendations for weight gain on table 13.2, and they look at the amount of weight gain that is recommended. So that's there. That's on page 412. I'm not going to go over it in here. You guys can reference it in your text. Low back pain is something that also is not just independent of pregnancy, but it is often related to pregnancy in the sense that it's related to weight gain, and so therefore it usually is hand in hand with pregnancy. The hormone relaxin may contribute to low back pain, but it also affects other joints in the body and may lead to inflammation and pain. Now, relaxin also helps with making the joints a little bit more mobile and movable, which helps to open up the hips so a baby can actually pass through for delivery. So that's why it's important, but it can also impact low back pain potentially. Postpartum is the period following birth through about 6 weeks following delivery. During breastfeeding, which is not exclusive to postpartum, but that's when it starts, the menstrual cycle, and by association menses, may not return to normal levels until 6 to 9 months postpartum. So expect there to be a disruption there. That doesn't mean it's anything like the female athlete triad or anything like that. It's just kind of part of the body correcting itself and getting it back to that normal homeostasis that existed before a woman was pregnant. There are musculoskeletal changes in the pelvic floor muscles and pubic symphysis following pregnancy as well in that postpartum period. So why exercise? What's the big deal? What does it do? Well, like in the able-bodied population, muscle strength and endurance, and that's not to say that pregnant women aren't able-bodied, just general population. Muscle strength and endurance improve, more energy, better posture, which can help deter from some issues with bad posture and musculoskeletal conditions there, helps with sleep, helps with better moods. Backaches are going to be less. There's not as much bloating or swelling, not as much constipation. It also, for when the baby actually does come, by exercising more throughout the pregnancy, it can help to improve in the ability to manage the labor itself and allows for an easier return to the pre-pregnancy body shape. So they can snap back faster, easier as a result of all this exercise. Also, it's been thought that aerobic exercise training, so aerobic specifically, can reduce the incidence of gestational diabetes by about 55%. So highly recommended. Now again, you see I mentioned this at the beginning, most researchers agree that pregnancy, exercise in pregnancy is safe for mother and child. There is disagreement between them on those benefits of preventing preeclampsia, gestational diabetes, or perinatal depression. Again, use your judgment. It doesn't seem like there's anything harmful, so why not give it a shot? Because if it helps, great. If not, well, you're no worse off. Elevated maximal oxygen capacity postpartum, lower total body fat, and more energy expended during moderate exercise are other results of aerobic exercise, and no one is going to levy an argument against that. 150 minutes, same as everybody else. Healthy women who already do vigorous activities, they can continue to do vigorous activities while they are pregnant. Okay, this is not a disease. You are not fragile. But if you've already done vigorous activity, keep it up. However, pregnant women who were not engaging in that. They were previously sedentary or engaged in only moderate intensity exercise. It is not advised that you all of a sudden now begin a vigorous intensity exercise program. That is not a good idea. Again, tables. That'll tell you more about some recommendations. However, here's some things to know about when to stop. So if any of these happens, knock it off. Stop exercise immediately. Vaginal bleeding, shortness of breath before exercise, exertion, dizziness, headache, chest pain, muscle weakness, calf pain or swelling in the calf, preterm labor, decreased fetal movements, or amniotic fluid leakage. This is all serious stuff. Right? Obviously, you would want to stop. You also want to watch out for exercising in the heat. We're all Floridians here, so that's especially important. Make sure they stay very, very hydrated. Supine exercise, so exercise laying down on your belly, that is contraindicated after the first trimester of pregnancy. And then any activity that risks abdominal trauma should also be avoided. Postpartum, that exercise should be resumed gradually to allow proper readaptation to activity. Body just went through a lot of changes, depending on the method of delivery. Maybe there was surgery involved. All those things need to be considered. Now, pelvic floor exercises during pregnancy and postpartum, or sometimes known as Kegel exercises, that can assist the restoration of the musculoskeletal function of the pelvic floor muscles and can help to alleviate any urinary and anal incontinence, which no one wants that. So getting those muscles back in shape is going to be good. Also of concern, pelvic organ prolapse, sexual dysfunction, and chronic pain. So those pelvic floor exercises are advised. Now we move to later in life with menopause. During menopause, hormone levels change very dramatically, especially with estrogen. There's that estrogen again. We mentioned it a couple of times. We mentioned it in pregnancy. We mentioned it in female athlete triad. And here it is again, rearing its head. These changes bring about a loss of bone mineral. It can lead eventually to that osteoporosis that we've talked so much about this month. And of course, then the increased risk of fractures. Exercise, however, as you might have guessed, can actually help to have a protective effect on bone in this population. So it can help to reduce the impact of that lack of estrogen and help to make it so that not as much bone mineral density is lost. Menopause is characterized by the loss of ovarian follicular function and subsequent cessation of childbearing. So here we go. Here's a couple terms that are going to be important for you. The transition period between childbearing years and menopause is called perimenopause. And perimenopause lasts for anywhere from 5 to 8 years typically. Symptoms of perimenopause include rapid heart rate, vasomotor inability to regulate body temperature, so that's those hot flashes, mood changes, depression, irritability, anxiety, sleep disturbances, and even cognitive issues like a lack of focus or concentration. So all of this as a woman is transitioning between childbearing years and menopause. So that perimenopause is kind of like, I guess when someone says, I'm going through menopause, they're really talking about perimenopause. Postmenopause is after, and that's when it's all said and done, and there are no menses for a 12-month period in which a woman is not pregnant and not lactating. Because remember, those can disrupt normal menses, but this is different. This is a result of menopause. Some symptoms during this time, so during this postmenopause, night sweats, back and muscle pains, loss of lean muscle mass, weight gain, an increase in visceral abdominal fat, bloating, indigestion, constipation, heart palpitations, or some combination of all of them. So it's not a fun set of symptoms as a result. And again, with that estrogen decrease, osteoporosis is a concern. It makes the bones more porous, so there's more holes in them, and they're then more fragile. Less calcium in there. So this is very, very common in postmenopausal women. In fact, it is a primary risk factor. So other risk factors, and this is something that might show up on the quiz, being small boned, if you are of Caucasian or Asian descent, believe it or not, those make you more likely to develop osteoporosis versus, say, Hispanic or African American women. They have a bit better outcomes when it comes to osteoporosis development postmenopausal. So Caucasian and Asian descent, over the age of 55, family history of osteoporosis or hip fractures, if they're inactive, diet that does not have adequate amounts of calcium, vitamin D, smoking, and lots of alcohol, all of these could contribute to the likelihood for osteoporosis. We know a little bit about bones. They constantly are going through that renewal process called remodeling that consists of resorption, which is the breakdown or removal of bone, and formation, which is putting down new bone. Now, with osteoporosis, there's an increase in resorption or decreased growth, as during menopause, weaker bones will develop over time. So there's more resorption, less formation, thus less bone mass. There are some medications out there. The goal is to either prevent bone mass from making it so that it doesn't happen quite as much. If they take anabolic medication, that's to increase the rate of bone formation and bone strength. With anything we've talked about this month, lots of different med options. They can go through hormone replacement therapy, but there's a lot of side effects and symptoms along with that. So bear that in mind as a treatment option. And those, obviously, looking at them, headaches, nausea, fluid retention, well, those might impact someone wanting to work out. Speaking of working out, let's get into how we can help. Here we go. Regular exercise can help to alleviate more common symptoms in menopausal women by improving the cardiorespiratory system, psychological health, so keeping that nice and safe and sound, and overall quality of life. In addition, combination of aerobic endurance, resistance training, and mineral supplementation, so again, that vitamin D and that calcium, right, mineral, can improve blood lipids, muscular strength, and bone mass maintenance. There is some evidence that suggests walking, jogging, and running alone might not be enough for helping bone mass. So those are weight bearing, but there is some evidence out there that says that's not quite enough. So make sure there is some resistance training in that program. It is more important. If the proper progression is followed by less than 5% increase per week, that can actually have a more significant impact on overall bone health. If you're able to get somebody resistance training, again, doctor clearance will tell you more, but here's some suggestions. And finally, to end this out, to close it, there's a couple of slides that have some yoga positions. These are spine-specific exercises that are also recommended. Maintain good flexibility, strengthen the body, maybe even a little power training you see here. All good stuff for someone that is menopausal or postmenopausal. Guys, thank you so much for listening, for going through this. I know we don't do hybrids all that often, and listening to these is not the most riveting thing. You would have gotten the same exact thing had we actually sat in class, so at least there's that, and I don't have as many things to get me distracted as I'm recording this for you. But you can always refer back to this information and let it help you, especially if you're dealing with any clients with any of these conditions. I hope the information has been beneficial to you this month, but even more so, I hope that you've enjoyed the opportunities to talk with people with conditions, to talk with professionals that work with people with conditions, and to go and see some exercise options for these folks, because that will show you exactly what options are, and that is much more beneficial than any talking I could do out of a PowerPoint or out of a textbook. There is no substitute for seeing the real thing. Here's those last couple exercises. Hope you guys enjoyed this. We'll see you next time. This is Mr. J signing off for you.